Well, thank you so much, Dr. Nomathemba. So what we envisioned is a bit of a discussion where we have questions for you, but we also, this is not us talking amongst ourselves. We'd love for you to ask questions. Again, reminding everybody the goal of this session was to review the evidence, the research, but then to have real-world dialogue about what we should and shouldn't be doing. Just to frame a little bit perspective-wise, I'm adult and pediatric infectious diseases, meaning that I see patients from zero, but I can follow them all the way through life. So I say from the cradle and trying to avoid the grave. And many of our patients that I see are perinatally acquired individuals who are now 30, some approaching 40, and who have been told their whole life, just your viral load is fine. But now we're seeing the diabetes, we're seeing the hypertension, we're seeing the suicides, we're seeing the mental health. And so this is critically important to talk about at the beginning, all before it starts happening. So with that, would love to maybe talk a little bit, you highlighted it a little bit, but I want to maybe emphasize what you think are the major barriers to interventions, sustainable interventions in the real world, and for both mental health and cardiometabolic disorders. Start with you, Dorothy.
Are they just on?
I hope it is.
Yeah, great. Yeah, I think there definitely are barriers. I think stigma is probably one of the largest. Stigma is not accepted to say, I'm suffering of a mental health challenge. Like, we don't talk about it. So I think that is one of the first barriers, is just to get comfortable talking about mental health and bring it out of this spectrum of, a lot of times when we open up the door to mental health with youth, they think of the person who is psychotic on the street. And certainly that is a mental health disorder, but that's really at the far end of the spectrum, and there's a lot swinging up and down on that scale. Worth checking in, not just, habari zaleo, right? How's today? And everyone says nzuri, it's fine. But going a little deeper, like really checking in, are you okay? And so I think stigma and just opening the dialogue are critical and can go very far. And then when we get into real sort of group-based interventions, I think there really does need to be a champion. There needs to be a lot of leadership and support that says this is important. And people need to really dedicate time to training. I think that these interventions for youth, again, delivered by youth, are the most effective, but they take a lot of supervision, and supervision is really critical because you're putting youth forward to deal with a lot of really heavy situations. And if those youth aren't supervised, then they're carrying this burden and this load. And so it really is a collective job. So yeah, I would say it starts with literacy, mental health literacy, and just making it an open dialogue. And then it really comes into leadership and people believing that this is important and willing to put in the time and the effort to train and to supervise well.
I would say the reason barriers to these interventions are quality of life has not been prioritized among adolescents living with HIV. We congratulate ourselves of having people living longer lifestyles, longer lifespans, but what is a quality of life? And the second thing is that it's really difficult to change how we eat. Food is if you think of the food, you think about your parents, you think about your homes, it's culture. And the last thing is that obesity is not seen as a chronic disease. And like the advocacy that we had for many people in this room, where we stood up for better drugs, we also have to stand up and say excess weight gain is not okay. The drugs that we need to help us manage this disease need to be cheaper. So the advocacy that we've successfully been able to do to get a lot of other drugs available, we should do the same thing for mental health and excess weight.
Perfect. Thank you very much for the encouraging remarks around answering the most important questions. So I had a quick question, and then we'll take number 2 and take number 3 noted. Do you think young people feel like it is a problem? Even maybe speaking from a perspective, you recently said that we are supporting young people from a perspective of them being beneficiaries, but not them being leaders or maybe encouraging them to take a lead in these spaces. Can you maybe elaborate around that quickly? Thank you.
Yeah, thanks. It's a great question. So I guess just to start, from my perspective, do I think that youth see mental health as a problem? Is that the question? It's a great question. I mean, we have our youth here. I would love to hear you guys answer that question. I think it's mixed. I think for some people, and probably for many, they feel not okay. They feel like, why bother? And I think some feel like they're being a burden, and they feel like they should be better than this, they should be stronger than this, and they feel weak and they don't know what to do. And maybe many of them don't talk about it. And so I don't know if there's realization of what's going on. I think they know something's wrong, but I don't know if they could label it as, I'm feeling a mental health challenge right now. I don't know that that's in the vocabulary, but I think they do know something's not right, and they're not sure how to fix it. And I think the first step to that is having a support network where you can go and you can really share what's going on. And then within that support network, if it's your youth leader at the table, that they are skilled to triage. Is this just we need to talk about it and kind of talk through what's going on? Or is this really elevated and I can refer you? I think there has to be referral systems. I don't think talking to your peers is necessarily the final stop, but I think it covers a lot of it. And then there's maybe you need to go on for some specialty care potentially. So I think we have work to do on naming what that is. And I think with COVID, I think it was there before, but I think the places that young people can express are in schools and at home. And when lockdowns happen and you didn't have school, and then family is totally stressed out and you're just like another problem, maybe even incurring some of the domestic and abuse that's happening with no outlet, so I think that the issue was there, and is there, but maybe not named quite in that exact way. But I would love to hear if that resonates with our youth. That's just my perspective.
Invited any youth to come and say it. I think before you jump into Nomathemba, one of the things I wanted to say about that is I think we have normalized mental health problems with mental health as a normal thing, right? Families, et cetera, there's so much anxiety, depression that exists. And so trying to say, hey, I'm not okay, but everybody around you also looks the same, it's even harder to then break that, right? And say, we're all collectively not okay, right? I think identifying a youth with issues, you probably can find a parent, a guardian, that it's around all of them. Go ahead about the cardiometabolic.
So around cardiometabolic, I think we are a little bit behind, particularly with perinatally infected children and adolescents, where we've been wanting them to gain weight, we've been wanting them to grow. So now, looking at the reverse problem, we don't see it as a problem yet. And I think being a young person is difficult. I mean, you are struggling with a lot of things, so excess weight just in the general population of young people is tricky with Instagram and other things as well. I often say that I'm glad I was not a teenager when Instagram was there, because it's a lot of visions that you're seeing, from Kim K's BBL, and if anyone understands that, you're allowed to come to the party. You see all these visuals around what is appropriate. And also, make no mistake, there are a lot of people who are invested in seeing us get bigger. So I'm not one to always be around conspiracy theories, but around big sugar. Why is it so difficult to get healthier food? You go to a place and water and a soft drink cost the same. They shouldn't. So there are some investment, our gym memberships, etc. So it's tricky. And the other thing is that I just think of the many problems that young people have. This is seen as further down the list, where it should be, because it's not only a problem for now, but it's a problem for the future.
Thank you very much, Dr. Nomathemba. And I would like to acknowledge maybe questions from the floor. I'll first take number 2.
Thank you very much. I'm Dennis Nwagawa from Uganda, and my question goes to Dr. Dorothy. I know we are all struggling to integrate mental health in HIV care, and this being a new area, we are starting on baby steps. Recently, we did an assessment on what are the available resources to integrate mental health in HIV/AIDS care among the children and adolescents. But however, there is still limited information and tools and training manuals. And actually right now, we also don't have clear indicators. If we did an intervention, what are those indicators? What are the simple screening tools we can add during HIV testing? So I beg, or I will contact the doctor or others in this room to guide us to think together on how we can strengthen this area. It's a new area. The youth have peculiar needs, and we may not design it the way it is for the adults. We may need to be very innovative. Thank you very much.
Thank you. I think number 1, is there a question over there?
Thanks. I have a question to Dorothy. So I work in an HIV prevention program for adolescents and young people, and we are looking at mainstreaming and sort of integrating mental health literacy and support, psychosocial support into our program. And it's been quite challenging to find like information or research around that's adolescent friendly, and more so resources like screening tools. And so in looking at getting our first line responders or our community level interventionists to have mental health literacy, but also still maybe scale on like screening and identification of mental health symptoms before the actual diagnosis of bringing in psychologists, because as you're saying, mental health support is sort of quite an expensive resource. And so we're looking at mainstreaming that and integrating different workers and first liners. But I'm wondering, are there any sort of screening tools that have been validated that we can maybe look towards and integrate into our program?
Should I go ahead and answer? Yeah. Okay, so thank you for both of these questions, and I think they're somewhat similar in what I'm hearing of challenges with screening tools, what's valid, how do you kind of get started on this? So first of all, thank you for recognizing that this is important and sort of starting the process of how are we going to do this. I think that's the first step, so that's really exciting to hear. The screening tools that I have seen most often used are like the PHQ-9 for depression. So that's PHQ, Patient Health Questionnaire, 9 questions. There is an adolescent version to that, and there is one that's just 2 questions. So the question always comes, well, is it validated in my context, right? Because these sort of are starting in maybe a more higher income country, and then they kind of filter in. But there has been quite a bit of work done in PHQ-9 across Africa in different contexts. We've definitely used it with adolescents in Tanzania, and it's being used quite a bit across Sub-Saharan Africa through the Patch Network. I think I'm not part of Patch, but I'm part of AHISA, but we kind of share meetings, and I know they're working really hard on harmonizing mental health tools, and that is one for depression. For anxiety, the one that I'm most familiar being used is the GAD-7, so the Generalized Anxiety Think Disorder tool. It's 7 questions, and it's also kind of aligned with PHQ-9 and how you would tally things up. Usually a cutoff of 10 is kind of, if you score 10 or higher, that's kind of a moderate to severe kind of score, and would definitely need some attention. So those are 2 tools that I would recommend. And I guess the other thing to say is we focus a lot on the disorder side, but again, just remember this is a continuum. So I think that's a good place to start, but I would also just recognize the wellness side of it, and there are tools for that too. How are you doing from a self-efficacy standpoint, from an esteem standpoint, from a resilience standpoint, and there's markers for that too. So then you kind of have to balance how many tools are we going to ask people to answer, right? And you have to kind of then prioritize what's important. But I would say to start, there are like the CETA, the MH GAP action plan. There are some of these adolescent-specific interventions. Ours is protocolized. It's online, and I'm happy to share it for scale. But as I said, it's intensive. These aren't things that you sort of read the book and you go off and do it. You really need some training behind it, and you really do need, I would say, a really skilled social worker, or if you have a psychologist, to just sort of supervise so that the youth who are out there delivering these things have someone to go to for help. I think that's really important, that we can't just sort of roll this stuff out willy-nilly. There does need to be someone with some knowledge to handle the really difficult cases. And so that's probably how I would build it out, is start with some of these tools that have been validated, like the PHQ-9 GAD-7. If you're so inclined, some resilience, some sort of how are we on the wellness perspective as well? And then start groups. I think support groups in Africa, I think that works very, very well. I think it would work great in the United States, but the US is very individualistic, and HIPAA rules and all kinds of red tape. I've been trying to get groups back in the US for a long time, because I think that's what youth are. You thrive on peer. And so I think when we kind of bring you out and put you in a little white room with a doctor and a couch, that doesn't go well. And so use our peers as leaders, train them up, give them jobs. We need jobs for youth. This is a great opportunity for employment. Then they really learn a lot of skills. Our group leaders come out on the other end oh my God, I'm a new person. I'm so I accept myself. I'm okay. I can go save the world. So that's kind of how I would recommend building things out. It's hard, but it's so worthwhile. It is so, so worthwhile.
So Dorothy, I'm just wondering, because you talked about groups and getting people in the same room. We have lots of young people on there WhatsApping, Instagramming, all kinds of stuff. I wonder if you can talk about virtual and online tools for mental health. And I have a question for you after that, Nomathemba.
Yeah, I avoided that one.
I know.
I had a slide for digital, and I just deleted it, because I think it's kind of a mixed. I don't know the answer on digital. I will say COVID forced digital interaction a lot. I think we're all in this room and happy to be here, and not, for those on Zoom, I wish you were here, but we're fatigued, and I think youth are too. So I think it's a great option. I think there's not a one size fits all. So I think if you can have flexibility in this, it's really great. But I would say my impression from hearing from youth is they'd rather be in person. They'd rather talk to each other face to face. And I agree, I think around social media, it's an amazing tool that can be very positive, but it can also be very harmful. And so I think it's really, if you have a safe space where youth can come, there's all kinds of questions around confidentiality, right? If you have an HIV positive group and you're online, and who's joining and who's gonna know my status, and then you're telling these stories, and is it gonna get out? And I don't know. So it's a great question, and I don't feel like I'm equipped to give a thoughtful answer beyond I'm not sure yet. I think it depends.
Yeah, no, I hear you. I want to ask you a quick, oh, go ahead, you were going to make a comment.
No.
I was going to ask you, because one of the things you talked about was just what the kids walk by on their way to school, et cetera. I'm wondering if you could talk a little bit about how we educate even on what is healthy nutrition, et cetera. Because I feel like we could all use, who had breakfast this morning? Raise your hand. Who had, proudly, I had a croissant with chocolate, right? So I think part of it is even education on what is healthy, what's not healthy. I think that's missing. I'm curious if you can talk a little bit about where we're missing for HIV and beyond.
Okay. So the focus on excess adiposity should be not around the weight gain itself, but health. But how do we become healthy? Just like you want your viral load to be suppressed, what kind of foods fuel you to be healthy? With that said, the food pyramid that we have currently, it's about to be changed. It's actually not based on any scientific data at all. You know, the 3 fruits and carbohydrates, etc. It's actually hogwash. So a lot of what we think is healthy is actually not so healthy. You know, and if you think of like how we think fruit juices are healthy, but fruit juices have got more sugar than a Coke. And so and a lot of the way that we look at health messaging is quite Eurocentric. So if you think of the foods that most Africans or people in other parts of the world, you know, like banting or quinoa, I'm not saying, I mean, it's things that I discovered later on in life. So even within our different spheres and where we're from, there is healthy food available. But I think the emphasis should be, when we speak to our patients, we just say, just eat things as close to possible as they are made, right? So instead of eating refined mealie meal, eat umngushu, which is, you know, like, what is it? Sand, there you go, right? So just try, instead of bread, you know, eat things just as unrefined as possible. But also, just be kind. You know, we are human beings. Our food is delicious. And it's not a war on food. This is what it is. It's really around how do we eat better. And this is a question that all of us struggle with. But you try the best you can. And if you succeed 80% of the time, you're doing very well.
Thank you very much. I think I would support that and just say the less processed food is the most effective food. And then I will take number 3, number 2, and then take number 1. Noted, Chief.
Right. Good morning. Good morning. My name is Kodzai. I'm from Zimbabwe, from the UZ there. And thank you so much for the amazing presentations from both our speakers. I've got a couple of questions, I guess for both panelists, with regards to parental involvement, whether it's with mental health or diet and nutrition for the adolescents. It's great to have all these programs and interventions there, but you need the parental buy-in for these adolescents to be able to access that. So I'd love for you to speak a bit more about what that looks like with regards to how are you talking to the parents, especially in Sub-Saharan Africa, when you're speaking of mental health. It's something that older people they do not understand. It's something like, you know, you just need to get over it. What do you mean you're depressed? You know, everyone gets sad, you know, you just, you know, need to get over it. So how are you bringing in the parental involvement, both with diet and with mental health issues? And then I guess my second question would be for Dr. Doe. I'm new in the space of mental health and adolescence, and my work is specifically with sexual risk behavior. So I'd like to maybe if you could expand on how, in your research and what you found the impact of mental health on sexual risk behavior, as I feel that would be important as we are now rolling out all these various PrEP interventions into this population. Thank you.
to add something now. Okay.
Is that okay? Okay, thanks. Thanks for those excellent questions. So I thank you for underscoring the parental involvement. I think it is absolutely critical. In the interventions that were presented just quickly, they do involve caregivers. So I'll speak to Sautia Vijana because that's the one I know best. And yes, we involve caregivers. And the first time, our first session, in the first session, we asked caregivers to join the youth. And so, as you know, if youth are under 18 in Tanzania, and I think that might still be true in other countries, they need parental consent to join a research study. And so they've been kind of through the what is SYV, what is Sautia Vijana, but they weren't coming to the first session. And so the youth said, we need to go to their house. We need to really explain this because everyone's busy and it's really important. And so we started doing a home visit beforehand. So even though there was consent, the group leaders go to the house and really sit with the caregivers about what is this, what is mental health, and really kind of check in where are they, and then kind of start wherever that level is. And often it is, it's putting it on this continuum that we don't think your child is psychotic or anything. We're just giving good coping strategies. And by the time the caregivers understand, they say, why is there not something like this for us? Why is this all about youth? We need this too. And it's true because, parenting determines kind of how kids are going to cope with the stress that they need. So we do need one for caregivers and parents. It's just sort of pole. We're going to deal with adolescents first, and I think that will come. But there are plenty of interventions for parenting as well. But we do have to have the caregiver at the table, and we try to do that and really explain what is mental health and what we're going to do for the youth. We give the caregivers a space to talk about their own challenges, but make it really clear that this is driven for youth. And so one of the unique things with SYV is we unpack the trauma narrative of when the youth learn they live with HIV. And as you all know, many of these youth, at least I also work with a lot of perinatally infected children, their parents have died, so their caregiver is someone else. And so often the youth has this story, and it's the youth story of how they learn they live with HIV. Often it's different than the caregiver, and they're not really aligned, and they haven't talked, and the caregiver has this perception of the youth, and the youth has this perception of the caregiver, and that story, that coming together and just talking, has done tremendous amounts of good for opening communication and just understanding each other. And I think if you don't have that openness, it's really hard when you're not okay to reach out to whoever your caregiver may be. So that's a long soliloquy on parent or caregiver involvement is critical, and I think most of these interventions, if not all, really try to incorporate caregiver support. IMARA particularly is around PrEP and around sexual risk behavior, and they do that intervention in parallel with parents, so that might be one to look into. I don't know it intimately, but it's in South Africa and does have some good data. Definitely mental health challenges are associated with higher risk sexual behavior. If you're not feeling so hot about yourself and someone's interested in you, you're probably willing to kind of do whatever. You might not have a lot of self-esteem to sort of stand up and say, no, that's not what I want to be doing. Or you might be, more inclined for substance use, and then you might not be making good decisions around what you're doing. So I think all of these things certainly roll in and play a part. And so many of these interventions are really around good coping, really being aware of what your values are, how to make decisions according to value. So SYV incorporates strategies from trauma-informed cognitive behavioral therapy, how your thoughts influence feelings and behaviors. And the parents kind of learn a little bit about that, but want more. We talk about interpersonal psychotherapy and kind of relationships, circles of support. And then we talk a lot around motivational interviewing or naming your value and how are you going to make decisions based on those values. And so all of this kind of bleeds into how to stand up against, sex that you're not interested. How can you say no? How can you be empowered? How can you have that esteem? Those kinds of things. I hope that sort of answered the question, but yeah, thanks for the parent involvement because it's critical.
And likewise, thanks for the question. Parental and caregiver involvement is important when it comes to health and weight management. Early on in the pandemic, we had nutritional support programs. They've kind of fallen away, where we had community gardens, caregivers, particularly women and grandmothers, were taught how to feed young children. That's fallen away, but also this doesn't continue into adolescence. It kind of stops when kids are 2 years old and on solids, and that's kind of it. Adolescents are it's a special population. For example, the average adolescent needs 10 to 14 hours of sleep. They need more sleep than children actually do for them to grow. But people who live with adolescents will wake them up. You know, the fact that school starts so early, it's difficult. And also how we model our own behavior as caregivers and is important. I mean, I have a daughter who's 6, and I've had to be very careful about how I describe my own weight journey and how I describe how I look and how I feel about myself. Weight stigma and shame is most of the time, it's by the age of 9, the average girl starts to feel bad about her body, you know. This is really sad, you know, if you think about the journey that most people have from childhood all throughout their lives, worrying about, can I fit into this size, etc. So how we model and speak about weight is very important as caregivers and parents.
Awesome. We are over time. Yes, and they're burning questions. So I'm going to invite those microphone 2, 1 who have questions to come up. I think that was a perfect way to end it, is to talk about it's not just what is happening in the provider-patient interaction, but it's layers around the relationships, parents, et cetera, but also our environment. We have policy people here, and so what are the things that we can collectively do to be addressing mental health, nutrition, metabolic disorders beyond? Thank you both for fantastic presentations. Thank you for all those who came up and asked questions for us to have a discussion, and please do come up and ask those to our presenters as well. Thank you very much.
And then thank you very much for the good presentations, questions, high participation, high engagement. Thank you very much. And then lastly, I would maybe like us to take a short break. Maybe we'll come back around 5 to 11, preparing for the first session, or 11 o'clock. Am I right, Alice? And then can you kindly please don't forget to write your inspirational ideas on those charts, preparing for the upcoming poem for the closing. Are they serving the break down? Okay, please go down. Thank you.